So I'm going to show you a few additional techniques you can use in more difficult cases or where cases kind of seem equivocal. You don't need to use this in every case. That's straightforward and easy. But if you have a difficult case, these additional techniques can add information to the diagnosis. So we're going to talk about two qualities we can assess with pulse wave Doppler to help us assess proximal and distal patency. One of those is augmentation and one of those is phasicity. Augmentation assesses for distal patency of the vein, and phasicity assesses for proximal patency. And we'll take a look at those. Say we find the femoral vein and it seems like it collapses, but we still have a high clinical suspicion, or maybe it's difficult to collapse because the patient has a lot of edema, pain, or there's some other reason they're very obese or they're sitting upright because they're uncomfortable lying flat. Sometimes there are reasons it's hard to compress, but we're still not sure it's a real finding. One, don't hesitate to seek help from a consultative or a comprehensive ultrasound as soon as possible in these cases, but also there's some other tools that you can use. So how do you assess augmentation? Essentially, you identify the vein of interest. So in this case, it looks like someone's left femoral vein. We just place our pulse wave Doppler gate in here, and we should see pretty low velocity, kind of flowing waveform. And if we give a squeeze to the leg distally and try to squeeze where the vein is, we should see a spike in velocity as the blood squirts up that vein. And if we see a nice spike, then that suggests the distal part of that vein is patent. If we don't see a good spike and we gave it a good squeeze over the area of the vein, then that suggests is not definitive for a possible obstruction downstream. When we apply Doppler, squeeze and get a spike, this is called augmentation. Augmentation suggests distal patency. Now the next thing is, even before we assess for augmentation, when we place the Doppler gate in that vein, and maybe it's the femoral vein, we should see some variation, some low velocity, but still some variation in the velocity of the blood in the vein due to respiration. And this is a normal finding. This is called phasicity. If we see phasicity, which is a normal finding, this suggests proximal patency. It's not definitive, but it suggests proximal patency. If we don't see phasicity and we see just a flat line the whole time, whether they're breathing or not, then that would suggest maybe there's a proximal obstruction. So here's an example we can see quickly where a patient had a proximal DVT on the left side. So on their normal side, their non-affected side, this is the patient's right, we can see as we place Doppler in their femoral vein, we see phasicity. We see this gradual, somewhat faint change due to respiration. Whereas on the other side, one, we notice this vein is much more distended. And when we put Doppler in that vein, we see it's just a flat line suggesting a proximal obstruction. So that's how phasicity can help us in some select cases. 95% or more cases, we don't even need these things. We just need compression or not. Okay, a few pitfalls. Things to look out for. Make sure you're looking at the deep veins. They're always going to be touching arteries. Don't get fooled by looking too superficially and focusing on superficial veins. If you don't see an artery next to it, if it's not deep enough where you see some kind of muscle and connective tissue and things around it, it's probably not correct. If you don't see bone when you compress, then you may not be looking deep enough. Don't be fooled by lymph nodes. Sometimes they can mimic or look similar to DVTs, but if you fan up and down past them, you'll see that they don't continue to go anywhere, so that can help you. And another piece is when you find these veins, you want to have your probe oriented vertically so you're pushing straight down towards the floor on them. If you don't press vertically, then you may not get complete compression and you may end up with false positives. So here's one of the pitfalls. So in this example here, someone was kind of focused on these superficial veins, and we'll notice one, they're kind of high towards the top of our screen. We don't see big arteries around them, and we kind of see multiples, so that's a clue these aren't the right ones. Here's another example where I think the user thought maybe this was the artery and they thought this was the vein, and they're like, oh, it looks like it's kind of collapsing, and called this negative. However, further interrogation would reveal these are the same exact cases, only we've adjusted the depth. You see in both of these cases we're almost 6 centimeters in depth. This whole thing is the vein that's hugely distended with a huge amount of clot within it. And in this example here, these are actually superficial veins that were distended due to collateral flow because this is a deep vein and it's completely clotted and will not collapse. So make sure you're imaging at an adequate depth. Make sure you look for the arteries in contact with these deep veins. That's the most common and number one pitfall of all DVT ultrasound. The next one, not as common, but this can happen. Lymph nodes, especially if they're swollen, can look kind of like a vein with clot inside. Here's an example of a lymph node, but if you fan up and down and scan through it, you'll usually see, okay, it doesn't go anywhere, and usually it's got like this dark appearance with this bright white hilum. So here's another example. Just look out, make sure you're seeing the artery and it's in contact, and that will help you as well. Here's another one. This is a smaller lymph node. This one probably wouldn't be mistaken for venous thrombosis, but just so you know what lymph nodes look like and how sometimes they can look similar to DVT. Make sure you find the arteries that should be next to them in contact, scan up and down the leg looking for compression, and you shouldn't make this mistake. So just circles around where these lymph nodes are. So those are the big pitfalls. Number one, by far, making sure you're imaging at adequate depth. Make sure you see the artery of interest and the vein in contact with it. And when you compress, look for bone down deep at the lower end of your screen. That's a clue that you're down looking deep enough. Lymph nodes, just make sure you scan through them. Anything you think is clot, scan up and down, look for compression, and make sure you see the artery next to it, and that'll help you avoid that pitfall. And like I mentioned before, make sure you're trying to compress vertically so that you fully collapse the veins and don't lead to false positives.